Okay, so we're running just a little bit behind. I may have had a couple of technical difficulties, but hopefully not too terribly bad. Welcome to lecture number 3. We have a truckload of content to get through, so I'm not going to waste a whole lot of time getting going. But I do want to cover a thing or two just super quick. Let me change my share here. Um, and talk just briefly about the student portal. You should have received an email that had this information in there. This is where I post the recordings of all the lectures. It's also where I'm posting a lot of other information. And so if you don't have the email to log in here, email me, send us a message, and I'll get that back out to you. But each of the lectures is going to be listed all the way through lecture 16, the advanced pelvic floor. If we go in and look at the website here, there's going to be 2 tabs. You have to select it and then move off to the right and then click on it. Here I'll have both a PDF copy that you can download of the PowerPoint itself, and then above is the video. You click that, and it'll take you to a YouTube link that has the entire recorded lecture. There's also the post-lecture assignment below that, so we can click that again, come down to the post-lecture assignment, and then we see that. And I know that seems like a long time ago, but not that long ago for what we're doing. So we'll also move down. In last lecture, we had both the recording and the PDF download, but also the assignment under the lecture recording. I'm also listing all the videos of all of the needle stick placements that we do for that lecture. So for for last week or for last lecture, that upper cervical, the lower cervical down at T4, the interspinalis down in the lumbar. So anyway, just videos of all of those sticks so that you can have them. I'll do longissimus and multifidus here just briefly. I'm going to see if I can mute this when it starts to play. So there's a little introductory screen here. We get to the first screen, tells a little bit more about the origin, insertion, innervation, and action. Play a little bit further. I'll hit pause again. And then we get to the actual procedure, just written out. Again, you can pause here to take a screenshot if you want, however you want to get access to that. And then it'll move straight into a little discussion of the procedure itself, and then we finally get to a further out view of the needle stick, and then we get a nice uptight, nice close view as well. So as we go through these this week, the lecture recording is not available yet because we haven't done it. So, but the PDF download is available, and then as you can see, we have a lot of sticks placements that we'll do in today's lecture. Again, a lot of this is pre-recorded so that you have access to it online for any other time and for after even the course is finished. All right, so I'm going to stop that share and move over back to our PowerPoint. Again, a lot of content to cover today. If you have questions, feel free to post it in the chat and the question area, and Ashton will yell at me and give me the answer. So number 3 here, the junctional zones. Here we're talking about the shoulder and the upper arm. Sorry, my brain took a break there for a minute. I thought I missed a lot of my content. Junctional zones, thoracic, and then lower pelvic rotator cuff, the shoulder and the upper arm. We will cover here the upper traps, the lats, again, multifidus, spinalis, longissimus, iliocostalis. On the anterior torso, this lecture will hit pec major. In the pelvic rotator cuff, we'll hit the glutes, TFL, piriformis, and then the smaller, deeper rotators of the hip. When we get to the appendicular structures in the shoulder, we'll look at deltoid, infraspinatus, teres minor, teres major, and then in the upper arm, coracobrachialis, biceps, brachialis, and then brachioradialis. Some supporting evidence. I want to go ahead and jump right into this. I won't spend tons of time. I do not remember whether or not there is a question on these or not. I honestly don't think so, but just want to make sure we throw a couple out there. Here, a study from actually very recent from James Dunning and the Spinal Manipulation Dry Needling Institute group. They looked at spinal manipulation and electrical dry needling in patients with subacromial pain syndrome. Ultimately, we looked down further. The conclusion: cervicothoracic and upper rib thrust manipulation combined with electrical dry needling resulted in greater reductions in pain, disability, and medication intake than non-thrust peripheral joint soft tissue mobilization, exercise, and interferential current in patients with that shoulder pain. That shoulder cervical pain. And their effects were still maintained at 3 months. So I said in the introduction, dry needling is not the only thing we need to do. We have to have some sort of manual therapy involved to get good long-term benefit. As a clinician, it's nice to be able to put both pieces in there. It's nice to have both tools just in case a person is extremely phobic to dry needling, or if they are for some reason, more aggressive mobilization and manipulation is contraindicated. Another study by Brennan from 2017, and it looked at dry needling versus cortisone injection in the treatment of greater trochanteric pain syndrome. We frequently see very frequently, people going in to get injections for that greater troch bursitis. It's been documented fairly well, the benefit, of dry needling for that greater troch bursitis. And I feel like we do a little bit better job simply because we look at more structures, more muscles, the bursa itself, and the movement patterns whenever we're looking at treating that, as opposed to just dropping a needle in and injecting cortisone. And their conclusion off of their study was that cortisone injections for greater troch bursitis, it did not provide greater pain relief or reduction in functional limitations than dry needling. And their data suggested that dry needling is a non-inferior treatment alternative to cortisone injections. So it's also well addressed the limitations and the potential adverse effects of repeated cortisone injection in and around soft tissue. Dry needling, we don't get that. So really nice to see some good research out there on a couple of really common conditions, both that subacromial impingement and that greater trochanteric bursitis. So into our clinical decision-making, our movement system abnormalities. So we'll look at all 5 of them here. For the posterior scapulothoracic region, we have to evaluate and potentially treat all of these areas: the scapula, cervical, thoracic spine, the AC, the SC joint, and the shoulder. I don't list it, but we also may have to look at the first rib, the costochondral junctions, and the anterior torso. So thinking of that pec major area, we need to evaluate what's happening with the shoulder, down deeper into the glenohumeral joint. Again, the AC-SC joints, and then the sternocostal joint as well. Further on the spine, down low around the hips, the pelvic rotator cuff. Here we need to look at the lumbar spine, the sacroiliac joints, any sort of pelvic function, whether a pelvic floor or obliquities in that area, and then out laterally to the hip joint. All of those have to be evaluated and potentially treated for what could be considered a simple focal point of discomfort. In the shoulder, we have to look at the cervical spine down to the first rib. Again, the SC-AC joint, glenohumeral joint, and even further distally down to the elbow. And then in the upper arm, again, the glenohumeral joint, have to look at the anterior torso, and further distally again the elbow. So we have to make sure that we're looking in a lot of different areas for this movement dysfunction, this problem that we're trying to consider dealing with. If there's a pain dysfunction present, we have to look at these different areas. So when we're addressing these movement system abnormalities, the things that we have to assess, and again, this is similar to what we said last time, we need to look at our strength, our specific myotomes. We need to address any range of motion limitations. So have them, if it's a shoulder, have them go through flexion, extension, abduction, horizontal abduction, internal, external rotation, compare unilateral, compare it to bilateral, and look for any asymmetries there. Also want to look at any abnormalities in that movement pattern, whether it's with their pain pattern, if it's a focal, if it's very specific to one specific area, or if we've got some radiation. If there's some radiation, we have to determine if that's more of a spinal segmental radiation, or whether it's just a tissue radiation. And we want to assess tenderness. We'll look at specific patterns, areas that we need to assess for tenderness in each of these systems. And then need to address any altered sensation. There we want to look at either spinal segmental dermatomes, or whether there's some entrapment that we're dealing with peripheral innervation. For the cervical thoracic, or the posterior scapulothoracic, what we want to do first is look at the cervical and thoracic vertebral springing. Do we have one segment that is really responding? Are we provoking some significant pain or reproducing their symptoms with that vertebral springing? We then want to go through our palpation exam here in the upper quadrant. We want to look at C2 to T12, those paravertebrals from the spinous process laterally past the iliocostalis. So catch all of that musculature in there. I mean, you're going to check for any tender bands or nodules, and we want to look at left versus right. We need to do the same thing with the rhomboids, with the upper traps, upper and middle, and some of the lower traps, and then the levator scap as well. Do we have some significant tenderness or movement dysfunction there? Serratus anterior, may want to go into that chest wall and palpate to see if there's any involvement there in that area. And then lastly, the rotator cuff itself sits. Again, we want to identify those tender bands and nodules and compare left for right versus right. And then is there any aggravation through active, passive, or resistive movement? So we want to really try to dial down through all of that tissue to find out where our symptomology is coming from. For the anterior torso, we want to do some costosternal springing. So we want to follow those ribs let me bring that down just a little bit, from the first rib right underneath the clavicle on down, and see if we are eliciting any significant discomfort there. Then we want to go through our soft tissue palpation. Specifically want to look at pectoralis, follow the clavicular and the sternal attachment of pec major. We want to go look at the pec fibers lateral to the breast, and then posterior in the middle deltoid. Do they have some sort of tissue banding? Very common to get a lot of pain along that split between deltoid and pec, and we have to make a determination, which tissues are in charge of that. Want to drop distally down onto the deltoid tubercle. A lot of tenderness in and around the shoulder itself. We see down in the deltoid tubercle. So if we find something there, we may, instead of just looking at the anterior torso, need to look at the rotator cuff itself a little bit more to see if there's something going on there. And then evaluate the short and the long head, the biceps brachii. Again, tender bands or nodules, and then comparing left to right. Also the aggravation, always through active, passive, or resistive movement. In the pelvic rotator cuff, again, we want to start with our lumbar vertebral springing. Get on those spinous processes and really spring those vertebrae to see if you can identify a specific level of problem. Where is this being aggravated at? More than likely, if you get a specific segment that is a positive for a springing test, then you're going to find some of those issues related to that. For our lumbar tenderness, we'll look at T12 down to S2. Again, the paravertebrals from the spinous process laterally past the iliocostalis. We want to palpate along the iliac crest. We want to take it all the way down to the PSIS and then drop off immediately into the SI sulcus. We want to take it further distally and palpate the ischial tuberosity and the proximal hamstrings. We want to look at the greater tuberosity distally and proximally up to the iliac crest. Then we want to go superior to the iliac crest and look if there's any sort of tenderness away from that iliocostalis longissimus bundle deeper into the QL. And then is there a pelvic floor issue? So in the pelvic rotator cuff specifically, there are a lot of pain symptoms that represent anywhere from L2 all the way down to distal to the ischial tuberosity. And just without going through a palpation assessment, the patient's not going to specifically know exactly where it is or what muscles are involved. And following this pattern will give you a good idea of which structures are involved. So again, that 3D anatomy really helps dial that in. In the shoulder, we want to palpate for tenderness in the shoulder. So we want to start with the cervical paravertebrals. I don't have it, but we could also look at some gentle cervical springing as well to see if there's a segment that's provoking these symptoms. We want to also look at the upper trapezius, and then in addition to that, upper trapezius is almost always going to be involved with any sort of upper body problem. But then we want to look and see, is there a first rib issue going on? Just a little mobilization on that rib. We want to palpate further laterally down to the deltoid tuberosity, both in the deltoid and on the tuberosity itself. We want to palpate through the supra and the infraspinous fossa, so we can run across the fibers of those muscles and palpate for any significant bending. A little bit harder to find it in the supraspinatus. You'll just find a general idea of tenderness. Hard to differentiate that from the upper trap, but you can do a little bit of resisted abduction and you can break those two out. Infraspinatus is very common to have tender bands in that muscle belly just distal to the spine of the scapula. We want to move further. We want to look at pec major and latissimus from their origin all the way lateral to their humeral attachment. And then we want to palpate onto the coracoid itself. So we've got several structures that attach there, and some of them can be frequently involved with our shoulder issues that come into play. So we need to make sure we do a good palpation of that area. We also want to go into the biceps, the short and the long head, try to trace it from its distal insertion, and then follow it all the way back up to both the short head coming over to the coracoid and then the long head as it travels underneath the acromion. Again, we're identifying tender bands or nodules, comparing left and right. And then lastly, in the upper arm, here we want to palpate the shoulder, the biceps and the triceps. We want to catch the brachialis. We'll go through this a little bit later. And then we want to look at the lateral forearm extensors and the medial forearm flexors. Again, we're looking for tender bands, nodules. Where is the focal point of discomfort or focal points? So our 3D anatomy, I've recorded all of this. So these are the areas that we'll look at to save time. I'm not going to read that. We'll just jump a little bit further down. Okay, so in our junctional zones, and I refer to this as the scapulothoracic region and the pelvic rotator cuff. So posterior scapulothoracic, we're going to look at upper traps, latissimus, multifidus, spinalis, longissimus, and iliocostalis. Very similar structures that we looked at, cervical spine versus the lumbar. Upper traps, here the origin, I'm going to move my picture out of the way so I can see. Upper traps, the origin, the upper nuchal line. Actually, I'm going to stop my share momentarily. This is a little bit easier. Or pause that thought. I want to roll way down and see if I cover this in my video. Yes, I do. So take it away. So let's take a look at our three-dimensional anatomy in the posterior scapulothoracic region. The structures we'll look at are the trapezius, upper, middle, lower, latissimus, the multifidus, spinalis, and then the longissimus and iliocostalis. So let's start with the trapezius, both the lower, let me catch up, the lower, middle, and upper portions there. With the upper trapezius, the origin is going to be in the external occipital protuberance and the superior nuchal line of the occipital bone. And I don't have the nuchal. No, there's the nuchal ligament. It's also going to attach on the nuchal ligament, and it'll start with the spinous process of C7. As we move down with the middle and posterior fibers, we'll continue to attach to the spinous processes all the way down to T12. The insertion on the posterior aspect of the lateral 1/3 of the clavicle, let me get that rotated around. So all the way on lateral third of the clavicle, on the acromion itself, and come all the way down. It's going to ultimately attach down the spine of the scapula itself, the lateral half to third in the inferior fibers. Trapezius, any upper body dysfunction that we're dealing with, good odds we're going to have some sort of dysfunction with that, especially the upper trapezius fibers. More often than not, it happens right in the mid-belly between the superior nuchal line and the acromion, just a mid-spot right about there. So we move on to the latissimus. On the latissimus, and let me zoom in a little bit here. For the origin of the latissimus, it's going to be the spinous process of T7 to T12 and then L1 down to L5. Actually, let me hide or fade the traps. So again, similar to the trapezius, really broad muscle. It also has an attachment, or the origin via the thoracolumbar fascia down low, and then the 9th to the 12th ribs, and then probably most specifically down the iliac crest in this area, right there before the fibers of longissimus go beneath it or anterior to it to prevent it from attaching to the sacrum. Its insertion is on the humerus, so we look at an anterior view, and as I rotate around, it's going to insert just medial to the intertubercular groove. So that's the groove where the long head of the bicep sits as it comes over the humeral head, heading toward its attachment over here on the glenoid. So really an anterior attachment there, resulting in a really strong internal rotation effect with that. So we'll move back to the posterior aspect and look at the muscle. Let's look at multifidus first. In multifidus, again, we've looked at this before, but the origin, the posterior superior iliac spine, the dorsal surface of the sacrum, and the longissimus is sitting on top of it, so you can't see that, but the dorsum of the sacrum, the mammillary processes in the lumbar spine, the transverse processes in the thoracic spine, and then the lateral articular processes of C4 through C7. It inserts into the spinous processes of the lumbar, thoracic, and cervical vertebrae all the way up to C2. Again, as we talked before, it does not continue on to C1. And again, it is the prime stabilizer in the spine, cervical, thoracic, and lumbar. Then we'll move from multifidus onto the spinalis. We have both the spinalis cervicis muscle and a thoracis. In the cervical spine, here our origin is the nuchal ligament and the spinous processes of C7 down to T2, so right through here. And then its insertion is into the spinous processes of C2, 3, and 4. So 2, 3, and 4. And again, action in all of the erector spinae group, their action is going to be extending and either laterally flexing or rotating in this case the neck, at the cervical vertebral joints. We move further distally into the thoracic spine, and then we'll see the spinalis thoracis. So here, the origin, the spinous processes of T11 down to L3. It inserts in the spinous processes of T2 down to T8. And again, extends, laterally flexes the trunk. So I've specifically mentioned the spinalis. As we are dry needling into our target tissue, most of the time going to be multifidus. We take that measurement that we talked about, 1 finger breadth lateral from the superolateral aspect of the spinous process. We're definitely going to go through spinalis as we're headed towards that laminar backdrop as we're trying to dry needle multifidus. And so that's spinalis. Let's look next at longissimus. 3 distinct muscles with longissimus. The biggest is longissimus thoracis. I still refer to it as lumborum in the lumbar spine, but its origin, spinous process of L1 through L5, in the dorsal surface of the sacrum and a little bit over to the iliac crest. It inserts into the transverse process of the lumbar and the thoracic vertebra, and the 2nd to the 12th ribs. As we start to get into the thoracic spine, you will start to see a little bit of a lateral migration away from midline of the longissimus thoracis. So we move a little bit more into the cervical region. Then we find 2 more smaller structures. One is the longissimus cervicis, because it attaches to the cervical spine, and medial to that is the longissimus capitis, because it's attaching to the skull. So the longissimus capitis, here the origin is the transverse process of C4 down to T4, and it inserts into the mastoid process, get a little closer view there, of the temporal bone. We look laterally at the longissimus cervicis. Here, its origin is going to be the transverse process of T1 to T6, and then it inserts into the posterior tubercles of the transverse processes of C2 through C6. And so just lateral to the articular pillar. We will find when we get to the advanced cervical piece, we also have some correlation here with the scalenes, and this is where we start to look at using the lateral, the articular pillar, especially at a certain level, for dry needling a large number of these muscles all at one time, including some of the scaling. And so that's longissimus. Let's look lastly at iliocostalis. We do have iliocostalis lumborum. Again, its origin is the iliac crest and the posterolateral aspect of the sacrum. It inserts into the transverse processes of L1 through L4, and then the angles of the 5th to the 10th ribs. As we get to the 10th, 11th rib, we're going to see that iliocostalis move a little bit more lateral with respect to this paravertebral group. And partly that is because this is also the location where iliocostalis thoracis originates and takes off between iliocostalis lumborum and longissimus thoracis. Here, iliocostalis thoracis, the origin is the angle of the 7th to the 12th ribs. It inserts into the angles of the 1st to the 6th ribs. So it is possible, and we will address this when we get to the needling of this. It is possible to needle into that angle. It is a much higher skilled needling concept, simply because of this danger zone of the intercostal space and the potential for entering the lung field. So there we have the posterior scapulothoracic 3D anatomy. Next, we'll look at the anterior torso.
So I spent a good bit of time going over 3D anatomy. I have all of the dry needling treatments
spelled out very well, this many finger breadths, this many finger widths, and so forth. And that's great, but it's important to be able to understand what structures you're needling through to get to these specific areas. So again, the importance of the 3D anatomy. So let's move on to the surface anatomy palpation lab. I'm going to leave this here. It's going to be in the downloadable PDF, but we'll go directly into a video of the lab itself. So let me drop down. Of note, and we'll talk about this in the video, what we're interested in are 3 specific landmarks. Finding the spinous processes is important. That'll help us find the superior angle of the scapula, the spine of the scapula, and the inferior angle. Or actually, I should say those things will help determine what levels we're at. So we'll move further down. Actually, before I do that, as you look at this picture, it's also important to note that the vertebral body itself, let's say at T1, the spinous process is just a little bit inferior, but relatively in the same plane as the vertebral body. As we get further down, say to T9, the spinous process is significantly inferior. So the spinous process of T9 sits at the vertebral body of T10. So as you're palpating, you just want to be aware of where your structures are and what segmental level you're actually at. All right, so the posterior scapulothoracic surface anatomy. Let's start first in finding T11, T12. Here, quite simply, we're going to find that bottom rib. We're going to follow it medially until we reach the spine. The spinous process cranial to rib is T11. The spinous process caudal is T12. So let's identify that. And I'm just going to palpate for the inner spinous space. And so here's the inferior aspect and the superior aspect. So here is 11, here is 12. Quite simply, we can now follow these ribs, these spinous processes, as we come more cranial. And in the thoracic spine, there can be quite a distance between. And so rotated with the head, it's going to, spinous process will rotate as well. And there's one. So you can follow those processes all the way up to get up to T1. Okay, so let's then talk about some reference points, both at T1 and at T3, T4. Before we do that, let's outline the margin of the scapula. So we'll look at the inferior border first, and then we will follow the medial border of the scapula up. And want to get all the way to the superior border. Superior border dives a little bit deeper, so a little bit more challenging to palpate there. But there we have coming up and over. Another area we want to look at is the upper, or the more cranial, the more caudal piece of the spine of the scapula as it dives into the root of the spine of the scapula. Okay, we can follow the upper on out to the acromion itself. That's similar with the inferior border. So we talk about T1. The superior angle of the scapula is basically going to sit, give or take, at the spinous process of T1. If we look at the root of the scapula, now this scapula is actually up just a little bit. However, it's going to sit between the spinous processes of T3 and T4. So that's a really nice way for us to locate that spinal level. If we drop down further, between T7, again, his scapula is sitting a little bit high, and I may have drawn it just a little high. It's basically going to correlate across in between spinous process of T7 and T8. So as we're palpating also, we come off of the spinous process. You can move laterally onto the transverse process. And then as you move out a little bit further onto the rib itself, you can actually locate the costotransverse joint where the rib comes and starts its articulation with the transverse process. So when we start at T1, talking about transverse processes in relation to the spinous process. At T1-2, if your finger is on the spinous process of T2, then the transverse process is going to be 1 finger width cranial to that. So its transverse process is going to be sitting a little bit more superior. And that's for T1 and T2. If we're at T3, T4, then on that spinous process, now the transverse process is going to be 2 finger breadths above. And this all allows for the orientation of the spinous process in that particular vertebral segment. So we're at 1 finger breadth cranial, at 1 and 2, at 3 and 4, it's 2 finger breadths cranial, at 5 through 8, now we're up to 3 finger breadths cranial. At 9 and 10, we're back down to 2 finger breadths cranial. And then for 11 and 12, we're back to a single finger breadth cranial for the orientation of the transverse process to the spinous process.
Not repeat that again. So let's look at the posterior scapulothoracic treatment. That's a lot of words. So we've got the spinalis, rotatories, and multifidus that we'll treat in one needle location. We'll move. Well, looks like we're going to go ahead and do that. And so let's go ahead and bring in our video here. For the thoracic spinalis, the rotatories, and the multifidus, the patient's going to be in the prone position. Needle length is going to be 20 to 40 millimeters. Backdrop here is going to be the thoracic lamina. Precautions here, the lung field, the medial branch, the posterior ramus of T6 and T7, anterior ramus of T8, 8th posterior intercostal artery in the vein. We're going to palpate for the spinous process of T7 at the level of the inferior angle of the scapula. Needle placement is 1 finger breadth lateral from the spinous process. Angulation at 15 to 20 degrees caudal and medial. Okay, so now let's look at the interspinalis. Similar to what we did in the lumbar spine, we can do that. We've got a lot more space to needle here with the interspinalis. Again, as we move through the videos, you'll see that they can be on the student portal. You're able to stop and look at the needling instructions in a lot slower detail than what I'm giving you here. So I encourage you to go back before we get together for lab and look at that. For the interspinalis, position is going to be prone again. Needle length is less than 20 millimeters. There is no backdrop here. We're going to palpate to find the interspinous space between T7 and T8. When dealing with the spine, this will be the only time that you will have a superior needle angulation. Here it's going to be 15 to 20 degrees anterior, superior, perpendicular to the skin surface. Again, caution for the depth, less than 20 millimeters to avoid the spinal canal.
And so I'll demonstrate on this particular needle stick. I used a 3 centimeter or a 30 millimeter needle, and I'm aware that I didn't go further than 20 millimeters simply by the 1 centimeter or the 10 millimeter length of needle that I have resting outside the skin. So a nice way, if you don't have a 20 millimeter needle, which they are available, but if you have a 3 millimeter needle on interspinalis, you can just leave a centimeter of that out, and you know that you've got your depth correct. Okay, then on to longissimus and the iliocostalis. Again, this is all prone, so we will move into that.
For the thoracic longissimus and iliocostalis, again, the patient's going to be in the prone position. Needle length will be about 30 millimeters. There is no backdrop. We're going to grasp the lateral border of the rectus spinae group with a profundus grip. We're going to apply firm pressure, splay the index and middle finger. We're going to needle 3 to 4 finger breadths lateral to the spinous process of T7 with a 50 to 60 degree medial and a 15 to 20 degree caudal angulation in each plane perpendicular to the skin surface or relative orientation of the vertebral lamina with no backdrop.
So on that, we have a really oblique angle. Main thing we want to do is make certain that we don't drop down into that lung field, yet get plenty of penetrating depth through iliocostalis and longissimus. So we'll move on to latissimus. Again, a nice big muscle belly that can provide some really nice needling.
For the latissimus, the patient's going to be in the prone position. We're going to use a needle of 30 to 40 millimeters. Backdrop, there is none. We're going to grasp the muscle near the humerus, pulling it away from the body using the fingers to block the rib cage, palpating for the thickest part of the muscle. We're going to needle posterior to anterior, medial to lateral, parallel with the rib cage, using the fingers to determine appropriate depth.
So with latissimus, definitely you've got to really dig in, get your fingers up underneath that muscle to lay up against the rib cage. And that's just to protect. As you advance the needle, you're going to use your fingers. You'll feel the pressure of that needle approximating your fingers. I have done this many tens of thousands of times, and I have not one time let that needle advance through the patient's skin and to pierce into me. So the needle definitely gives you a sense of approximation and is completely safe to use that. Biggest thing here, you want to make sure that you needle away from the body to avoid the lung field. And then lastly, here we'll move into the upper trapezius. Again, we're going to do this in the prone position. When we do lab, we'll also do the lab in the prone position. Again, it's a nice, safe place. The upper trap is a very responsive muscle to dry needling. There's more research out there on dry needling of the upper trapezius, quite honestly, because it gets such a good response. So with that, we can also see that we get that vasovagal response. So that your patient doesn't end up lying on the floor. We'll always do this, especially as you get started in the prone position.
For the upper trapezius, patient again is going to be in the prone position. Needle length here is going to be 40 to 60 millimeters. There is no backdrop. We're going to palpate for the thickest aspect of the muscle belly. We're going to grasp the muscle between the thumb posteriorly and the fingers anteriorly, at least 1 thumb breadth above the supraclavicular margin to avoid the apex of the lung. We're going to insert the needle into the muscle in a posterior to anterior trajectory using the fingers opposite the insertion point as a guide to determine needle depth.
So upper trapezius can also be needled in the supine position. And either position that your subject is placed in, the objective is to move away from the clavicle anteriorly. Again, the proximity of the neurovascular bundle right there and the potential elevation of the lung field above the first rib. We want to take an angle, in this case, from posterior inferior to anterior superior. We still get lots of that muscle tissue. Nice, again, here's the term, nice trigger points right in here. And so good response in that position. And so if we do all of those at one time, that's kind of what we look like. We've got the upper traps, we've got iliocostalis and longissimus here. We've got multifidus, rotatories, and interspinalis here. And then we've got, or spinalis, and then we've got interspinalis here, and then the lats out lateral. So let's move into the anterior torso. And in this introductory lecture, we're just going to look at pec major. Other structures in here, absolutely, we needle them all. This is a nice one to get started with for simplicity. There's an ambulance going by, so just have to ignore that part. The pec major we'll look at. I should have an anatomy. Yes, let's just jump straight to our 3D anatomy for this.
Let's move on to the three-dimensional anatomy of the anterior torso. Here we're going to limit ourselves to the view of pectoralis major. So pec major, the origin, anterior aspects of the medial half of the clavicle. Get a view right there. Medial half of the clavicle, down on the manubrium in the body of the sternum. Change my angle a little bit there. And the superior 6 costal cartilage, the aponeurosis of the external oblique, abdominal oblique as well. And so we've got a fairly large location there. Interesting, I'm going to come up and pull up just so that we have a frame of reference here. Let me make this happen. So let's look at the left trapezius. So we've got a really close approximation of the insertion. So the upper trapezius on the clavicle attaches on the posterior aspect, while pec major attaches on the proximal third to half
of the clavicle on the anterior inferior surface. So some really big, powerful movers attaching onto that structure. Its insertion is the posterior, wrong muscle. Let's get to pec. Insertion at the crest of the greater tubercle of the humerus. So I want to move over to, well, one thing that's very interesting with pec is the wrapping and the orientation of the fibers themselves. We look at a posterior view, the inferior, the sternal muscle fibers, you can see cross and come more, let me get rid of that, have a more superior orientation onto the insertion, whereas the superior fibers, or the clavicular portion, comes down, wrapping around a little bit more down to the inferior aspect, and then the middle fibers just coming basically straight across, medial to lateral. But I want to look on the model here on the right side to look at the orientation and the workings of pec major, the long head of the bicep, and then latissimus. So we talked about latissimus, which sits right here, attaching to the medial aspect of that intertubercular groove for the biceps long head. Well, we then see the pec major just going just lateral to that intertubercular groove to attach onto that crest. So an interesting way to recognize the level of attachment of both of these muscle groups, or muscles as they attach on the proximal humerus. So that's the pectoralis major and the anterior torso. Next, we'll move on to the pelvic rotator cuff. Okay, so before we move on to the pelvic rotator cuff, let's look at treatment. Here, obviously, we'll do this in supine. Pec major treatment is very similar to latissimus. The key is really getting your fingers deep into the axilla to separate those fibers, protect that chest wall, and identify your needle location. Pectoralis major, the patient is going to be in the supine position. Needle length will be from 40 to 60 millimeters based on patient's habitus. Backdrop, there's going to be no backdrop in this situation. Again, with the patient in the supine position, shoulder will be abducted to 90 degrees and then externally rotated. In that position, we're going to grasp the muscle with the fingers in the axilla, blocking the rib cage, palpating between the thumb to locate the thickest aspect of the muscle. We're going to pull the muscle away from the rib cage, and we're going to needle medial to lateral, parallel with the rib cage, using the fingers as a backdrop to determine appropriate depth. Caution here to avoid the lung field. Okay, so very, very simple process. As long as you go medial to lateral away from the rib cage, it's a completely safe location. You can use your fingers to approximate the depth to make sure that you get as much of that muscle tissue as you can, and get really good responses from pec major. So now let's move down to the pelvic rotator cuff. And I know I'm moving really fast. We're an hour in and we've got a lot more material to work on. So again, this will be recorded so you can go back and look at it a little bit slower if necessary. But the pelvic rotator cuff, here we're talking about glute max, med, and min. We'll go laterally to the tensor fascia lata. We'll come in and look at piriformis, and then we'll look at, and now nice thing, we're going to needle all of these as a single unit. But the superior, inferior gemellus, the obturator internus and externus, and then lastly, quadratus femoris. Again, the glute max being a big, occupies a lot of territory. We move a little bit further. We look at medius, and we'll talk about that more in the anatomy section of its attachment. Finally, gluteus minimus. Let's move on. We're going to cover this in the three-dimensional. Let's just jump right to it. But again, I talked about those small external rotators. Really small area. There's a lot of them. We can't really identify one. Well, there are two ways that we can catch them individually, or a few of them. But for our purposes, we'll needle all of this as a single unit with a redirecting technique that we'll demonstrate. And then piriformis, and then just rapidly moving through those. Again, I do have all of the information from Gray's Anatomy on there with the original pictures if you want to take a look at that. But let's look finally at our three-dimensional anatomy.
Okay, so let's move into 3D anatomy of the pelvic rotator cuff. Here we'll look at the gluteus maximus, medius minimus, tensor fascia lata, piriformis, the superior and inferior gemellis, the obturator internus and externus, and quadratus femoris. So let's start at the very most superficial with gluteus maximus. Close that, bring that up right there. All right, so gluteus maximus, the origin, the area of the ilium located posterior to its posterior gluteal line, the posterior aspects of the sacrum and the coccyx and the sacrotuberous ligament more deeply placed. It inserts into the tubercle of the iliotibial tract on the tibia via the iliotibial tract and the great gluteal tuberosity of the femur. Its action is extends laterally or externally, rotates, and abducts the thigh at the hip joint. So there is a location, we will get to this when we do dry needling, what I call a master point located right here. That is kind of the convergence of the upper or the outermost gluteus maximus. I'll hide that. And then medius, which we'll discuss next, and you can tell beneath that is minimus. So a really strong point for all that posterior hip musculature. So next we'll look at, let's go out of order here. Let's talk about TFL and the IT band. The tensor fascia lata, the origin is the anterior superior iliac spine and the anterior 1/3 of the outer lip of the iliac crest. It inserts into the tubercle of the iliotibial tract on the tibia via the iliotibial tract. And its action, it assists in medial rotation, abduction, and flexion of the thigh at the hip joint. All right, so, and whenever we palpate for this, we'll talk about it in the palpation lab, the IT band or IT tract is very prominent on the lateral aspect, and we frequently use that as a landmark coming off the greater trochanter up to the iliac crest. But let's hide that and that, and let's get to gluteus medius and then minimus. So gluteus medius, it is the origin area of the ilium located between the anterior and posterior gluteal lines, which with the muscles removed, you can see the gluteal lines. It inserts into the lateral aspect of the greater trochanter of the femur. So one thing of note, gluteus medius is inserts a little bit, now the arm's in the way, a little bit on the posterior aspect of the trochanter, whereas gluteus minimus inserts a little more onto the anterior aspect. So you can consider a line between them with medius posterior and minimus anterior. But gluteus medius, let me bring that back up. Its action is medially rotating and abducting the thigh at the hip joint. And so we'll hide medius and get down to minimus. All right. Let me catch up here. So gluteus minimus, the origin, the area of the ilium located between the anterior and inferior gluteal lines. So here's the superior gluteal line and then the inferior, and that sits right at that inferior gluteal line. It inserts into the anterolateral aspect of the greater trochanter, and its action also medially rotation and abduction of the thigh at the hip joint. So we'll move down to the
piriformis. The piriformis is, the origin is on the pelvic or the anterior surface. If we look through the foramen, you can kind of see, well, let's look at anteriorly. So piriformis, again, it has fibers that go around the sacral foramen, but it attaches very medially onto the sacrum. And then it inserts into the superior border of the greater trochanter of the femur. So when needling this, it's important to realize that it's not out lateral, it's on the medial aspect. And so to properly needle it, you have to come a little bit more medial to get into the bulk of the muscle. Also to be cautious with the piriformis of the sciatic nerve exiting the sciatic foramen as it comes down and travels right through here. So its action is it laterally rotates and transversely abducts the thigh at the hip joint. We'll move inferior to that, and then we will see the superior gemellus inserts on the medial aspect. The origin is on the ischial spine of the pelvis, and then it inserts very, very similarly to the greater trochanter, just inferior to the piriformis. And its action is lateral rotation and transverse abduction of the thigh at the hip joint. We'll drop a little bit more to the external, the obturator internus. So here at the obturator foramen, on the ramus, we can see, and I'm going to rotate a little bit here, we've got obturator externus and then obturator internus. For our purposes here, we're going to needle all of these, except the piriformis, all of these in a single needling redirection as we get more into the pelvic floor. Then we'll look at needling actually over into the muscle belly itself. But we'll try to just pick along the line of the neck of the femur to attack all of these muscles. But anyway, obturator internus, its origin, the internal surface of the obturator membrane and the adjacent bones. It inserts into the medial aspect of the greater trochanter, and its action is lateral rotation and transversely abducts the thigh at the hip joint. Again, let's move and look at externus, obturator externus. Here, the origin is the external surface of the obturator membrane. It inserts into the trochanteric fossa of the femur, and it laterally rotates the thigh at the hip joint. And so it is buried a little bit deep as far as its insertion. Let's see if we can trace it back. There we go. So just inferior and behind quadratus femoris. So next in line, we'll look at the inferior gemellus. Here, the origin is the superiormost aspect of the ischial tuberosity. It inserts into the medial aspect of the greater trochanter, and again, its action is lateral rotation and transversely abducts the thigh at the hip joint. And then lastly, down on the quadratus femoris, its origin is the lateral margin of the ischial tuberosity that inserts in the quadrate tubercle of the femur. Its action is lateral rotation of the thigh at the hip joint. And so those are the muscles of the pelvic rotator cuff. Next up, we'll take a look at the shoulder and then the upper arm.
Okay, so actually let's move on to our surface anatomy palpation lab. And for our model, we will get a lot more in depth as we get further into this. For this piece, we don't have to get into this great of detail. I did not give you any homework assigning drawing this out, so you're welcome for that. But it is very important to be able to identify the structures, specifically the piriformis and the sciatic nerve, and using these landmarks to find that. So as we move forward here, again, all the verbiage is there. Yes, there is a rear end. I could have covered that, but let's just jump right in. So surface anatomy of the pelvic rotator cuff. We'll start to identifying the iliac crest and the PSIS. So we can come down off of the 12th rib
Come on down, locate iliac crest. So we want to draw that from lateral all the way over until we locate. It's going to angle down a little. And our target here is we want to find PSIS. You want to come down and you want to find the inferior most aspect as well. Okay, we'll do that on both sides as we're coming down. All right, very good. So there's the iliac crest and the PSIS. Now what we want to do is we're going to draw a helper's line from the inferior aspect of PSIS. And we do that because that's going to help us identify in midline S2. So the next thing we want to do is we're going to locate the sacral horns. From there, we're going to create a helper's line from the sacral horn to the PSIS. You want to advise, if you're going to draw on your patient, definitely advise them of what you're doing. And right there. So sacral horn, and from this point forward, I will just simply use one side here. So our next helper line will be from the PSIS down to the sacral horn. We also want to divide this helper's line into thirds. So we have a upper, middle, and lower third. So next what we want to do is draw another helper's line, and this one is going to be from the PSIS down to the ischial tuberosity. So we're just going to come in, palpate, locate that ischial tuberosity, and it's pretty well going to be in a nice straight line. So that's our ischial helper's line. Next, what we want to do is roll our greater troch, roll our leg, so we can identify the superior most aspect of the greater trochanter. And then we'll draw that. Okay, so here we are with the greater troch. From there, we want to identify our piriformis. So piriformis, we're going to use two lines from this area. Our caudal border, or our inferior, will be from the PSIS to the sacral hiatus. And it's going to be the inferior line. So what that means is we're going to come from here to this line. If I can make that nice and straight. Okay, our second will be to the upper, the line at the upper where the PSIS is. And so our same spot here, I will come to right there. So here is piriformis, off the greater trochanter to the upper 2/3 of basically the sacral body. So we can also palpate for the superior gluteal nerve, and we can find that by splitting this upper line into thirds. And so superior gluteal nerve can be palpated at times at that mark right here. We can also look the inferior line. We can turn that into thirds as well, and we can use that to locate the inferior gluteal nerve. And that one's going to be midway between the marks. So here we'll have inferior gluteal nerve. If we want to trace the course of the sciatic nerve, it's going to come from the medial 1/3 mark of the piriformis to the halfway mark on the line from the ischial tuberosity to greater trochanter, and then straight inferior from that point. So we'll come from here out to our location here, and then completely inferior. And so that is sciatic nerve. Sciatic nerve. Okay, I'm going to pause that right there because as I'm watching this, that is not correct. So it actually travels from the mid spot of this middle section and then travels to the gluteal line. So it's really close to the ischial tuberosity that nerve really starts to come and take a distal approach. It's definitely not lateral. So for your notes, actually in the notes that I wrote, it's told correctly. If I could take an eraser and erase that, I would. But it travels to here and then follows a distal path right there. So let's look at the treatment here. This pelvic rotator cuff, you add some lumbar into it, and this is a bread and butter of everything, of a lot that we see in clinic. A lot of that low back and posterior hip pain complaint. This is a lot of what we see there. So let's go to gluteus maximus first. Gluteus maximus, the needle location, is that master point, that spot in between the greater troch and the PSIS. For the gluteus maximus, the patient is going to be in the prone position. Needle length here will be 40 to 60 plus millimeters. The backdrop is going to be on the ilium. We're going to locate a midpoint between the PSIS and the superior aspect of the greater trochanter. We're going to needle posterior to anterior with relative orientation to the ilium. Use the ilium as a bony backdrop. Caution here for the sciatic nerve. Proper angulation of the needle perpendicular to the ilium will place the needle superior to the sciatic nerve.
And now we're good.
All right. So I'll pause again. We talked in the introduction of the course that needle length is dependent upon the patient's habitus. Obviously, the derriere, the posterior side of people can vary significantly. There are times where a 4 centimeter needle might get this. I do utilize some 12.5 centimeter needles for some larger, more rotund posterior hips. Sometimes that 12.5 is not long enough. To date, I haven't found one longer than 12.5 centimeters. So we're limited by our tools, but needle length definitely depends on the patient's habitus, and obviously you start with that 4 to 6 centimeter needle. That definitely will let you practice with safety. So gluteus medius is next. It's going to be fairly close to where we needle for gluteus maximus. We just want to make sure that we separate those muscle fibers to be distinct in the event that we need to have that distinction. For the gluteus medius, the patient is going to be in the prone position. Needle length here is going to be 40 to 60 millimeters. The backdrop is going to be onto the ilium. We're going to palpate for the iliotibial band superior to the greater trochanter to the iliac crest. We're going to move 3 finger breadths posterior on the iliac crest and then insert the needle 2 to 4 finger breadths inferior
from the iliac crest into the muscle with an angulation into the muscle perpendicular to and using the ilium as a backdrop.
And then finally, the gluteus minimus. The gluteus minimus has a very similar needle location from the TFL. In this introductory area, we're going to needle them differently, just so that we can differentiate needling specifically the gluteus minimus versus the TFL. In practice later, you'll find that you, for ease of time, will needle them as a single unit. But for here, I want to differentiate. So gluteus minimus.
For the gluteus minimus, patient again is going to be in the prone position. Needle length is 40 to 60 millimeters, and the backdrop is going to be onto the iliofemoral ligament. We're going to palpate the apex of the greater trochanter and the iliac crest. We should palpate the IT band along this path. And we're going to insert a needle at a midpoint between the iliac crest and the trochanteric apex in a lateral to medial direction using the iliofemoral ligament as a backdrop.
And then to the tensor fascia lata, again, a very similar needling approach. In this situation, we're going to needle it just a little bit differently so that we can thread through those fibers. In another note, I've got in for the introductory needling sticks here. I've got our patient in the prone position doing this. As you get more advanced, more skilled with your technique, you may find that it's much easier, especially with your older population, to place them in a sideline position so that they can be more comfortable. And there's absolutely nothing wrong with doing that. The key is being aware of your three-dimensional anatomy so that as they roll, your position of angle needle placement remains constant.
For the tensor fascia lata, or the TFL, patient again is in the prone position. Needle length here is 30 to 40 millimeters, and there's no backdrop. We'll palpate the apex of the greater trochanter and the iliac crest. We should palpate the IT band along this path. We'll grasp the anterior aspect of the TFL with the fingers and the posterior aspect of the IT band with the thumb. At the midpoint between the two bony landmarks, we'll insert a needle and advance posterior to anterior, medial to slightly lateral towards the table, using your fingers as a backdrop to determine adequate depth.
If you wanted to be certain that you're in the fibers of TFL, you could resist abduction here and palpate for that muscle belly. At times, depending on girth, there may be some extra tissue in the way, and it's important to identify that you're needling not just into adipose tissue, but actually into the muscle belly as well. So testing and retesting just to verify, testing and retesting before the needle is placed. And so then onto the piriformis. Lots of piriformis problems out there. In this introductory piece, we're going to be needling the piriformis on the lateral aspect, primarily because of the location. Again, piriformis coming, the sciatic nerve, coming out. It's not presented here, but out between piriformis and the superior gemellus before it takes an inferior dive here. The later advanced lumbo-pelvic cord lecture, we'll look at how to needle off of the sacrum to get the more midline fibers of that muscle. But for our practices right now, we're going to needle it out laterally.
For the piriformis, the patient again will be in the prone position. Needle length can be 30 to 50 millimeters. The backdrop here will be the ischiofemoral ligament. For the lateral attachment, we'll palpate for the superior aspect of the greater trochanter and locate its medial most aspect. Needle insertion point is 2 finger breadths medial and 1 finger breadth superior, posterior to anterior, using the ischiofemoral ligament as a backdrop.
So then finally, let's look at how we're going to needle this group of small external rotators down below piriformis. So we'll demonstrate this, but it can easily be done with a redirection technique. We mentioned that in the introduction of the course. This is where it can really come into play.
For the superior gemellus, the obturator internus, inferior gemellus, obturator externus, and quadratus femoris. We're going to treat this as a single unit. We're going to be in the prone position. Needle length here could be 30 to 50 millimeters, and our backdrop is going to be onto the femoral neck. These muscles are most frequently needled as a group using a redirection method. We're going to palpate the superior aspect of the greater troch and then locate its medial most aspect. We're going to needle insertion point at 2 finger breadths medial and 1 finger breadth to 4 finger breadths inferior, PA, using the femoral neck as a backdrop.
Okay, so onto the appendicular regions. Here we're looking at the shoulder and then the upper arm. So in the shoulder, we'll look at deltoid, infraspinatus, teres minor, and major. We'll get to supraspinatus when we get into the advanced section of the course. I stay away from it at the moment simply because of the location of the lung field, and there's a technical component that we need to make sure that we can do well to avoid that. So let's look at our 3D anatomy. I'm going to move through the verbiage here, let you review that on your own time as you want to. Infraspinatus below the spine of the scapula, teres minor and major with a similar footprint. Major not part of the rotator cuff, minor definitely being as it comes up and attaches. And so let's look at our 3D anatomy.
And the 3D anatomy of the shoulder, or the introductory shoulder muscles, will get much more in depth in the later aspects. You'll notice that the supraspinatus is is absent from this section, and quite honestly, at this point, we leave that off simply because of the potential risk for pneumothorax if we go a little bit too anterior into this lung field, but we will get to that in the advanced shoulder. Here we'll look at the deltoid, infraspinatus, and then teres minor and major. So if we look at the deltoid, let me bring 3 different aspects of the deltoid: anterior, lateral, and posterior. You can see that the origin is going to be off the lateral third of the clavicle, then around the acromion, and then further back to almost all of the spine of the scapula. So it's got a very similar attachment to
the upper trapezius. Matter of fact, let's bring that on. Let me close this, and let's add in that left trapezius just to see how that looks and what happened. There we go. So as we look at similar, we had the pec major with a very similar orientation right here. The pec major will line up very closely to the most medial aspect of anterior deltoid. The orientation or the attachment of upper trapezius and the deltoid also shares a very similar footprint. All right, so let me hide that. The deltoid itself inserts into about mid-shaft of the humerus into the deltoid tubercle. It's, let me bring that up, there we go. Where'd we go? Its action is abduction of the arm at the glenohumeral joint. The anterior deltoid will also give a little flexion and medial rotation of the arm, whereas the posterior delt will also give us a little extension and then laterally rotation, and then also some transverse abduction at the glenohumeral joint. So deltoid there, complex muscle. Let's come to this side. I'm going to hide the deltoid here so that we can see infraspinatus, teres minor, and teres major. Infraspinatus, its origin is the infraspinous fossa of the scapula, so it takes up all of that territory, or most all of that territory below the spine of the scapula. It inserts into the greater tubercle of the humerus. I'm gonna get rid of the bursa for a moment here. So on the superior aspect of the humerus itself, when we look at supraspinatus, we're going to see that it has a footprint on this superior facet of the greater tubercle, and then it also comes over and has some mixed fibers in with infraspinatus as well. So its footprint goes from about the edge, the lip of the groove, laterally over the apex and then down just a little bit. With the infraspinatus, it is all on this posterior, this angled facet itself. The action is it laterally rotates and transversely abducts and stabilizes the arm at the glenohumeral joint. So the function of the rotator cuff itself can be considered the rotation, but on the true purpose of the rotator cuff is to provide stability of the glenoid in or the head of the humerus in the glenoid cavity itself. So infraspinatus will drop in to look at teres minor. Let me fade that. So teres minor, come out. So teres minor, its origin is the posterior aspect of the superior half of the lateral border of the scapula. So we split the scapula in half in the superior to inferior aspect, and that's going to be the origin of the teres minor. It inserts into the greater tubercle of the humerus, and it will be at the inferior facet of this rotator cuff footprint. Its action is laterally rotating, transversely abducting, and stabilizing the arm at the glenohumeral joint. And then finally, teres major. Its origin, the posterior aspect of the inferior angle of the scapula. It inserts into the crest of the lesser tubercle of the humerus. So this we see a very similar attachment site. If we remember, latissimus is also very close. So let me pull latissimus back up just for your orientation. Latissimus dorsal right. So we see it, the latissimus coming over, and it shares a very similar insertion as does teres major. Its action is adducts, medially rotates, and extends the arm at the glenohumeral joint. And that is our three-dimensional anatomy of the shoulder. So as we're here looking, I talked briefly about the three facets of the glenohumeral joint at the footprint. In our After we take our lab after the next lecture, we're not going to be needling out here. We're just going to needle into the muscle bellies themselves. But as we get into the advanced shoulder, we definitely can needle into that myotendinous junction onto the tendon at its superior, lateral, and inferior facets as well. So with our palpation skills, it's very critical to be able to identify the angles of those attachments. So let's look at our surface anatomy palpation lab. There is a lot of potential surface anatomy in the upper extremity. For our purposes, I'm going to keep it fairly simple. As we get into the advanced, we will have a lot more depth. So we won't necessarily identify all of these things in this. It is here for your reference, and we will come back to it in the advanced course. But let's just look at some surface anatomy for the shoulder and in the upper arm. And especially this is relevant to this introductory level for our first lab session. So one of the first things we want to do, we had already marked and identified the spine of the scapula coming laterally, but we can continue to follow that acromion as it makes its way to the anterior aspect. So we can palpate that coming on around. So we want to know where that acromion is. Another structure we want to identify is the deltoid tubercle. So you can have your patient abduct out, ab away to identify the deltoid tubercle. And it's going to end up being, give or take, halfway, midway point between the elbow and the acromion. So we'll call this our deltoid tubercle. You can identify the muscles of the deltoid itself coming off the lateral half of the spine of the scapula, and it will traverse. Here you can have them extend, and it'll go and extend backward, and you can see the fibers of deltoid there. Similar on the anterior deltoid, with its fibers coming off the lateral third of the clavicle. Go ahead and flex, and then you can identify those fibers as they're coming down to their attachment here. So deltoid muscle here, we want to find the lateral epicondyle. And so we identify here. And then we want to follow that up on the supracondylar ridge. And we can follow that a fairly good distance, almost all the way to the deltoid tubercle. So a nice traveling spot right there. One thing that we can do, go ahead and flex the elbow, give me to 90, and hold the thumb there. We can identify brachioradialis as it's traveling over to the supracondylar ridge. And it will actually be about right here. Go ahead and let that relax. Now, very important to note, posterior to the supracondylar ridge, this is all tricep. Anterior, we're going to have a bifurcation or two separate muscles we want to talk about. One, obviously, the bicep. So go ahead and flex again. We're going to hold right there. And so the bicep's going to be the bulk of all of this structure. Go ahead and let it relax. But then as you come off of the supracondylar ridge, you're going to feel a little bit more of a ropier muscle. And you can feel the bifurcation here. So here is brachialis. Then anterior to that is biceps. We identify the deltoid tubercle partly because we're going to use that a little bit later to needle into the distal fibers of coracobrachialis. So at this point, there's a whole lot more surface anatomy we need to get to, but for our needling session for lab number 1, these are the structures you need to identify. Okay, so on to the shoulder treatment itself. Infraspinatus, teres minor, major, and posterior delt. You can needle posterior delt lateral delt, anterior delt. You can needle them in a direct approach or in a threading approach. We're going to demonstrate the direct approach for the posterior delt. All right. So we already discussed anatomy. So let's move past on to treatment.
For the posterior deltoid, the patient will be positioned in prone and will be using a 30 to 40 millimeter needle. We're going to palpate to determine the posterior border of the deltoid while the patient abducts and extends into the resisting hand. We're going to grasp the medial aspect of the posterior deltoid with the thumb and the middle deltoid anteriorly with the fingers as a backdrop. We're going to direct the needle from the posterior deltoid laterally toward our fingers as a backdrop to determine the depth and needle angulation. A direct needling approach can also be used with needle oriented toward the humerus as a backdrop. So on the medial aspect, posterior deltoid.
Let's look at infraspinatus. Infraspinatus, again, a big muscle that creates a lot of issues. Get a lot of good relief from needling into infraspinatus.
Dry needling of the infraspinatus will be completed with the patient in prone using a 30 to 40 millimeter needle. We're going to palpate the midpoint of the spine of the scapula, then palpate for the inferior or caudal drop off in the infraspinatus fossa and needle 1 finger breadth inferior and a posterior to anterior angulation, perpendicular towards the inferior dorsal surface of the scapula as a backdrop. So the spine of the scapula, midpoint, 1 finger breadth, and perpendicular to the scapula.
Infraspinatus is a nice bread and butter, common, frequent needle placement. So the teres major would be next.
For the teres major, patient again is going to be in the prone position. Needle length will be about 30 millimeters, and here there is no backdrop. We're going to grasp the muscle between the fingers and the thumb, palpating for the thickest part of the muscle, making sure to identify the lateral scapular border and the ribs. Using your fingers as a backdrop, we're going to advance the needle through the muscle until you feel the needle approximating your fingers in the axillary side. Caution here regarding the lung field, that needle angulation will be slightly lateral.
In a perfect world, trying to get your maximum bang for your buck, getting you the most muscles with the fewest amount of needles. Teres major, at times teres minor, mainly teres major, and latissimus can be needled at the same time. And so finally, let's hit teres minor.
Teres minor will be needled in prone using a 30 millimeter needle. We're going to grasp the muscle between the fingers and thumb, palpating for tender nodules, making sure to identify the lateral scapular border and the ribs. Using your fingers as a backdrop, advance the needle through the tender nodules with a slightly lateral trajectory until you feel the needle approximating your fingers in the axillary side, with caution regarding the lung field. So the lateral scapular border, I can feel the ribs. I'm going to come in this upper third of the scapula in through teres minor.
Clinically, teres major, teres minor may not be critically involved with a lot of our dysfunctions, our movement problems, but however, it is important to be able to identify those structures and needle them when it's clinically relevant. Okay, so now let's move on into the upper arm. We've got about 15 minutes left. Looks like we're going to make it just in the nick of time. So here we'll look at coracobrachialis, the biceps brachii, brachialis, the triceps brachii, and then lastly, it's further distal than in the upper arm, but it has a decent footprint there, so I include the brachioradialis. I'm not going to identify, we've already talked about the surface anatomy here, so I'm not going to spend a whole lot of time on that. But coracobrachialis, its origin off the coracoid process. It inserts into the intermedial surface of the midshaft of the humerus. So we're going to take advantage of that at this point to needle coracobrachialis here. A little bit later in the advanced shoulder course, we will needle coracobrachialis off of the coracoid. At this juncture, we're going to stay in a safe zone and we're going to needle it right here. It's action, flexion, and adduction of the humerus. We look at biceps brachii, again, the two different heads, the long, which goes through the intertubercular groove over to the glenoid, and then the short, which attaches onto the coracoid itself. The short head sits right just anterior, more superficial than the coracobrachialis, which sits distal to it. Interestingly, our anterior fibers, or our medial fibers of our anterior deltoid, lie right over this as well. So this is a very common site of pain and discomfort. A person dealing with problems with subscapularis also sits right here. And so clinically, we have to differentiate: is the problem a deltoid problem? Is it a subscap problem? Is it a bicep problem? Is it a coracobrachialis problem? Nice thing is we can needle all of those fairly simply and just make sure that we get it right. It inserts into the radial tuberosity and then bicipital aponeurosis into the fascia of the forearm. Its action is flexion, supination of the forearm, and flexion through the short head of the arm. The brachialis, its origin is in the lower half of the anterior surface of the humerus. So actually, deltoid tubercle sits right here. So really close approximation there. Actually, I remember I do have a 3D anatomy of this. So let's just move on to that. Yes. And then let's look at the three-dimensional anatomy of the upper arm. Here we'll look at the coracobrachialis, the biceps brachii, both the short and the long head. We'll look at brachialis, and then we'll look at brachioradialis. So let's start actually with biceps brachii, then we'll remove it to look at coracobrachialis. So biceps brachii, both the short and the long head. Let's look at the short head first. The origin is the apex of the coracoid process of the scapula. So we have three distinct structures attaching onto the coracoid. Both the short head of the biceps, then the coracobrachialis, and then pec minor has an attachment on the medial surface of that coracoid process. It inserts into the radial tuberosity and the endobrachial fascia. So as we rotate down, we can see that coming. Let me go ahead and highlight the tendon itself, and that's its attachment there on that medial aspect of the radius. We come more proximally and look at the long head. So with the long head, the origin is the supraglenoid tubercle. I would have to, let me remove some structures here that are in our way so that we can see the path of the long head. All right. So as the long head comes, we're going to find it traveling all the way to the supraglenoid tubercle of the scapula. We'll take a look, posterior or a medial to lateral view of that. So we can see that as it's coming up and attaching on that tubercle. Clinical relevance, if they have a superior glenoid tear, frequently that's why we're not doing any resisted bicep to prevent any further tearing, or if there's say a slap repair, that's why we avoid that resisted elbow flexion. Its insertion again into the radial tuberosity. Its action is it supinates the forearm, flexes the forearm, the elbow joint, and it's most effectively when the forearm is supinated. So let's take that. I'm gonna hide now the bicep so we can get a look at coracobrachialis. And so the coracobrachialis, again, its origin is onto the coracoid process of the scapula. It inserts, so we can look from a medial to lateral view. It inserts into the middle third of the medial aspect of the humerus, and its action is abduction and flexing the arm at the glenohumeral joint. We move further distally, and then we will find brachialis. Its origin is the anterior aspect of the distal half of the humerus, and so I'm going to bring the deltoid back in. It's a nice landmark. Deltoid, right. So we look at the location of the deltoid as it attaches onto the deltoid tubercle. Just inferior to that is origin of brachialis. It inserts into the coronoid process and the tuberosity of the ulna. So whereas the biceps attaches onto the radius in this area, brachialis then comes down onto the ulna instead, but at a very close proximity to each other. Its action is flexing the arm at the elbow joint. And then finally, I include in this segment, because frequently if we're dealing with lateral issues, the brachioradialis actually comes up with its origin fairly high on above the elbow. So its origin is the superior 2/3 of the lateral supracondylar ridge of the humerus. So as you can see, its footprint comes up fairly high. It inserts into the lateral aspect of the distal part of the radius, so it travels quite a distance before it comes to attach. Its action is flexes at the elbow joint. It flexes the forearm, and so a powerful movement there. And that would comprise our three-dimensional anatomy of the upper arm.
You know, for some strange reason, I left off the triceps. I'll cover that. Maybe I'll throw that into the Facebook closed group. It would take too long to open up my app at the moment. For time's sake, I want to get through this. So look forward to having that coming. So let's move on to the treatment. As far as surface anatomy, all of these structures are definitely palpable. Most notably, we need to palpate along the supracondylar ridge to identify the ropi brachialis, further anteriorly for the biceps, and then posteriorly for the triceps. We're not targeting individual heads at this point, so we're gonna hold off on that. You do need to be able to identify that posterior border of the deltoid, however.
And so let's move on to our needle locations. We've got 1, 2, 3, 4, 5 needle placements here. All in this section, we will do these from a lateral approach. These can all be done from different placements, but here in this section, we'll do it from a lateral approach. So we'll start first with coracobrachialis.
For the coracobrachialis, the patient's going to be in the supine position. Needle length here is going to be 30 to 40 millimeters, and there is no backdrop. We're going to look at two approaches. First, from a lateral aspect, we're going to palpate for the deltoid tuberosity. We're going to grasp just superiorly to the tuberosity with the fingers, palpating for the brachial artery and thumb at the tubercle. From 2 finger breadths superior to the tubercle, we're going to needle from lateral to medial, just anterior to the humerus until you feel the needle approximating your your fingers. Your patient arm must remain in the anatomical position to penetrate the coracobrachialis. And this is done to avoid the neurovascular structures up higher. Alternatively, the muscle can be needled in an AP direction, 1 finger breadth caudal from the coracoid process, 3 centimeters of depth, with a slightly superior trajectory to avoid the brachial plexus, brachial artery, and vein.
Normally I would be on the same side as the treatment. However, for filming purposes, went to that side. So here, again, we're going to find that deltoid tubercle. We're going to move and needle just anterior to the humerus to arrive in the distal fibers of coracobrachialis. For the purpose of the lab that we do in 4 or 5 weeks, as soon as that gets here, I'm going to avoid the coracobrachialis demonstrated here. I want you to get a little bit more comfortable with needling before needling too closely into that structure. So we'll stick with the original needling approach. Okay. So biceps brachii, short and long head. We're going to treat these as a single unit at this point, and we'll do that in this area here. Again, patient's still going to be supine.
For the biceps brachii, the short and long heads, patient again is going to be in the supine position. Needle length will be approximately 30 millimeters. There's not going to be a backdrop in this technique. We're going to grasp the biceps in the mid-belly, pulling it away from the humerus. We're going to needle from a lateral to medial, anterior to the humerus, using the fingers as a backdrop to determine appropriate needle depth. In this case, I would normally needle on this side. Because I'm over here, my finger placement will be reversed.
So important here to differentiate brachialis from biceps so that we can identify and make sure that we're needling the exact structure that we're looking for. Perfect. Let's move on to the brachialis. Again, it's going to be a ropey structure right along anterior to that supracondylar ridge, in just posterior to where we probably needled bicep, maybe a little bit further distal.
For the brachialis, the position is going to again be in the supine. Needle length will be about 30 millimeters, and the backdrop here will be the anterior aspect of the humerus. From the lateral aspect of the mid-humerus, we're going to push the bicep medially. In my case, I'm going to pull it medially to expose the lateral portion of the brachialis, which will be a ropey type of muscle that you'll palpate there. We're going to needle from lateral to medial into the muscle using the anterior aspect of the humerus as a backdrop.
So again, in clinical application, biceps brachii and brachialis could both be needled from an anterior to posterior approach from the anterior aspect through bicep, through brachialis, down to the humerus as bone. I start this direction because it's important to be able to identify the specific structures just in the event that brachialis is the target structure that we're looking for. For the triceps, again, very similar location. We're just going to drop down a little bit further, and we drop further so that we can get all three heads of the tricep with a single needle placement.
For the triceps brachii, the patient again is going to be in the supine position. Needle length will be 30 millimeters, and there's no backdrop. We're going to grasp the triceps muscle proximal to the olecranon in the distal third of the forearm, and we're going to pull it away from the humerus. We're going to palpate for the medial neurovascular bundle so that we can make sure that we stay posterior to that. We're going to needle in a lateral to medial angulation with a slight posterior bias. We're going to use the fingers to assess for needle depth and direction away from the neurovascular bundle.
Again, normally I would be on the treatment side for filming purposes, moved so that you can see a little bit better. So let's wrap up with our last muscle, brachioradialis. You'll notice some of these dimensions that I've got, the cubital crease, the 3 finger breadths, and so let's look at it in this aspect as well.
For the brachioradialis, patient again in the supine position, needle length approximately 30 millimeters. The backdrop here is going to be the radius. We're going to identify the brachioradialis by resisting elbow flexion. In the anatomical position, we're going to insert the needle 3 finger breadths distal from the cubital crease, anterior and lateral, posterior to medial, with a 30-degree angulation with the radius as a backdrop. If you'll hold right there. Find me. Right there. Perfect. And let it relax.
So we've gone through, we've looked at all of our structures that we need to look at. Again, as we get into the advanced portions of the course, we'll get a lot more depth, a lot more detail. I do want to take a quick look at what we're going to talk about 2 weeks from now. we'll get a little bit more specific into the forearm, both the forearm extensor and flexor. We won't do all of these muscles on the next lecture. We'll actually treat these as a common treatment approach, which is always my first go-to approach anyway. Then we'll get into the upper leg. Here we'll look at the posterior thigh semitendinosus, membranosus, the biceps femoris, and adductor magnus. Anterolateral thigh, then we'll look at the quad plus the sartorius. We'll get down into the lower leg. We'll look at tibia anterior, extensor digitorum longus, extensor hallucis longus, and the peroneals. Superficial posterior lower leg, we'll look at gastroc, soleus, and plantaris. And then we'll get to the deep posterior leg and we'll look at popliteus, and then flexor digitorum longus, flexor hallucis longus, and tib posterior. We will look at some tendons and ligaments in the knee. We'll look at the patellar tendon or the patellar ligament. We'll look at the lateral collateral and medial collateral. And then down in the ankle foot, we'll look at the Achilles. So let's talk really quickly about your post-lecture assignment. Again, there's no needling, there's no drawing this time, just 5 relatively simple questions. Answers to all of these should be in the PDF version of the course that's on the online portal. Again, if you don't know how to get into that portal, please send us a message and I can make sure that you get there. But we got it done, 8:05, fantastic. I know it's a lot to process. I do recommend go back and review some of this material. The more that you look at before we get into the lab, the more familiar with it that you are, the easier that lab is going to be. So you may even grab a colleague and practice some of the surface anatomy because we'll run through that as well. And then we'll jump into all of the needling pieces that we've got. So I will have this lecture probably early tomorrow. I'll have the recorded version up on the portal for you to view again if you need to. And for those that weren't able to be online with us, they'll be able to view it then. If you have any questions, feel free to yell out, let me know. But good luck with these questions, and I'll see you in 2 weeks.